Hello everyone, this is Dean, and we're going to be talking about nutritional concepts today. I'm really excited. I think this is going to be a really fun topic. It's given me so much satisfaction to work with my patients in metabolic medicine. So why should we talk about nutrition? Well, first, there is an epidemic of obesity and diabetes going on right now. Docs need to understand this impact that nutrition is playing on our metabolic health, and patients and docs alike need to learn how to work together to improve health for everybody. So, our goal today is going to be to introduce some fundamentals, some important concepts to help you understand metabolic medicine. Now, we're going to start with nutrition research, and before we get started, there is no shortage of opinions when you come to nutritional research. This is really notoriously hard to do nutritional research. It's expensive, and there's a bunch of bad observational studies out there for sure. And it's really hard to get randomized controlled trials together. So let's look at some stuff that's coming hot off the press. These are This one is from the Journal of American College of Cardiology, just from August of 2020. It caught my eye right off the bat. It's a meta-analysis of a whole bunch of randomized controlled trials and some observational studies. But this is a high quality meta-analysis study, and the overall thing was to look at saturated fat. Should you be telling your patients to eat a low-fat diet or a high-fat diet? And this has been controversial in medicine for a while, and it is a reassessment of the recommendations. And the bottom line in this thing is that the meta-analysis found no significant evidence for restricting fatty acid intake in our diet. And that's really, really a big recommendation here. So a few of the finer points here on the highlights. The current recommendation is to restrict fatty acid intake, saturated fat, to less than 10% of calories of your daily calorie intake. And that's kind of where we are now. We tell our patients, don't eat fatty foods, Uncle Joe, because you don't want to get a heart attack. And but they're basically saying you can't just discount the fact that different fatty acids have different effects on our bodies. And so we have to take into account those things, and also with the carbohydrate intake. Really, really important. And so several foods rich in saturated fatty acids, and they make examples like whole fat dairy, dark chocolate, and processed meat, are not associated with increased cardiovascular risk or diabetes risk. And their final little highlight here is there's no robust evidence that current population-wide arbitrary upper limits on saturated fat consumption in the United States will prevent cardiovascular disease or reduce mortality. So that is a big conclusion. And this study had a study population of 400,000. So it's got a lot of power to the study, and they are well-designed studies here. So again, they make sort of recommendations here, that the recommendation to limit dietary fat in the intake has persisted despite the mounting evidence to the contrary. In other words, we keep telling people to reduce the fat in your diet despite all this mounting evidence that comes in, especially through studies like this, that say limiting the fat in our diet, the healthy fat, the saturated fat, is not a bad thing. It's not going to produce bad effects on our bodies. No beneficial effects for reducing fat intake on cardiovascular disease and total mortality, and instead found protective effects against stroke. And then this is a really interesting little part here. Although saturated fats do increase the LDL-C in most individuals, So in other words, whoa, wait a minute. Eating, increasing the fat in your diet does make your LDL-C go up. And you think to yourself, well, there you go. Well, that's the point. But it's really not the point, because it makes the point that this is not due to the increasing levels of small, dense LDL particles, but rather large LDL particles. And this is where we've got to do a better job of understanding the pathology of coronary artery disease. And the plaque, we've got to understand where the plaque is coming from. The plaque is coming from small, dense LDL. It is not coming from large particle LDL. And if you're somebody who's saying, what does all that mean? Well, again, stay awake, my friend. We're going to look at this in this little talk today. We're going to try to introduce these concepts of LDL-C, small dense LDL, and large particle LDL, and why eating saturated fat in the diet may raise LDL-C. It does not raise small dense LDL. And that's a big concept to get. And that's what I hope that we can help with in this talk today. Okay. Now that we beat that down a little bit, the Academy of Nutrition and Dietetics also came out with a statement that saturated fat should no longer be considered a nutrient of concern based on the lack of evidence connecting it to heart disease. And let me just say again, there are no randomized control trials that say saturated fat causes heart disease. They're just not. They just don't exist. Here's one from the British Medical Journal from 2019. It's kind of a retraction statement here. It says the preponderance of evidence indicates that low-fat diets that reduce serum cholesterol, which is kind of what we've been telling our patients, do not reduce cardiovascular events or mortality. Specifically, diets that replace saturated fat with polyunsaturated fat do not convincingly reduce cardiovascular events or mortality. And these conclusions stand in contrast to current opinion. And what is current opinion right now? Eat a low-fat diet to try to avoid heart disease. But again, the preponderance of evidence indicates that these low-fat diets don't reduce cardiovascular events or mortality. Here's one. I call this study, this was from 2019 also. It's a meta-analysis. It's what I call the shootout it's like the shootout in the OK Corral. It's taking several randomized control trials. Again, these are high-quality studies. It looks at 8 of them with 1,633 total patients. And it compares patients with a low-carb, high-fat diet to those patients eating a high-carb, low-fat diet. Okay? And it looks at them over a period of 6 months and 12 months to see the effects on their metabolic markers. So what did we see? So the first thing out of the box here is that there's not a big difference in the patients who are on carb-restricted diets versus the high-carb diets in terms of LDL cholesterol. In general, there is a little bit of a trend that the high-fat diet does make the LDL-C go up a little bit. And we've said this over and over. But again, we want to make the point that LDL-C is not the boogeyman that we've been making LDL-C out to be. The real powerful things that this study points out were that HDL cholesterol and plasma triglycerides were much better controlled with the low-carb, high-fat diet. And that we're going to talk about why that is. We're going to talk about the physiology of why that is. But it is a little bit of that quandary that you think to yourself, wow, eating a high-fat diet makes my triglycerides go down. And so it kind of goes against the way you would normally think. But again, these are very striking when we look at the results. And so, again, the conclusion of this study was that randomized controlled trials of at least 6 months duration with carb restrictions appear superior in improving the lipid markers compared with the low-fat diets. Okay, and that the guidelines, the dietary guidelines, should consider carb restriction as an alternative strategy for the prevention and management of dyslipidemia. And again, it kind of goes against your thinking here. To control the lipids, we want to lower the carbohydrates and increase the fat. That doesn't make sense, does it? If we lower the sugar, raise the fat markers get better over here. And that kind of goes against what doctors have been telling patients for a long time, but we're going to take a look at why that is. Here's the last study. This is another randomized controlled trial of looking at 46 studies with a patient population of 5,612 and a meta-analysis of 64 studies. And they compared low carb versus other diets such as low fat. Okay, so the low fat results are in red, the low carb are in blue. And these are the markers up here. These are the metabolic markers that they measured. They measured weight, HDL cholesterol, triglycerides, blood pressure, A1C, fasting glucose, fasting insulin, C-reactive protein, insulin sensitivity, and total cholesterol HDL ratio. And they looked and they saw which study here was superior for these particular markers. And so that being said, the low carb diets in blue outperformed all of the low fat diets, which were in red, for all of these risk factors. Now, there was one little caveat that the low fat diets did have a little bit of lower total cholesterol and LDL-C. And we've said this time and time before that yes, eating a low-fat diet does lower your cholesterol and your LDL-C a little bit. But as we're going to see, that's really not what drives coronary artery disease progression. And so the other thing is that the ratio, such as total cholesterol HDL and even other ratios like triglyceride HDL, may have a higher predictive value to predict cardiovascular risk than LDL-C, for sure. So, to look at these metabolic markers, again, the low carb approach, there's something about the sugar that is hurting our body metabolically. And we're going to look at why in just a minute. Let's look at some cases. Let's make it a little bit more real. Okay, here comes case number one. We're going to do 4 cases for just a minute to open this topic up. So case number one, a 50-year-old African-American male comes in for a routine CPE who's taking atorvastatin. Okay, atorvastatin again to try to control cholesterol. And the patient comes in and look, the cholesterol's 116, so we would say that's not too bad. Triglycerides are 88, that's not too bad. HDL cholesterol's pretty low. We'd probably talk to them about, trying to get that up a little bit. LDL-C is 65. I don't think I'd see anybody really fighting about those numbers too bad. And I trended it out over here. You can see how the patient not only is doing now, but doing for the last 7 years. So overall, numbers look good. But this patient has an ASCVD risk of 28%. That's a 28% chance of having a heart attack in 10 years. You say, whoa, but I don't see it in the numbers. Well, maybe he's on atorvastatin and that's why we don't see it. But you say to yourself, look, he's been on atorvastatin for a while, so it should be doing its job, right? Which is more accurate right now, the LDL-C in terms of risk, or is it the ASCVD risk? And then we know that he's got a HOMA score of 2.4. And then you say to yourself, well, what the heck is a HOMA score? I don't even know what that means. So the patient had a significant metabolic risk despite a normal LDL-C and a normal total cholesterol. And the question we want to ask ourselves is why? What's driving the ASCVD risk, or is it real? So we see the cholesterol, the LDL cholesterol, which is LDL-C, and his numbers look fine. I mean, the highest it ever gets is like 97. He comes in 65, 77 for the last few years. So it is what it is. But look, as of 3/2020, he has his first heart attack. The question is what happened? And how relevant was LDL cholesterol for his heart attack prevention? And did the atorvastatin do anything? Case number 2. This patient comes in for hyperlipidemia follow-up visit. And this patient has a total cholesterol of 94, triglyceride count of 268. Oh, so you think to yourself, well, that's pretty high. Non-HDL cholesterol 61, HDL cholesterol is low at 33, and LDL-C is low at 7. Is that too low? So the interesting thing, when you look at this kind of a case, is the patient is watching his cholesterol. He's eating a low-fat diet. So one of my questions is if he's eating a low-fat diet, trying to watch his cholesterol, and this guy is also taking atorvastatin 40 milligrams a day, why does he have such a high triglyceride count? I mean, he's not eating any fat. His ASCVD risk is 43%. His CAC is 297. So he has documented coronary artery calcium. His A1C is 7.5. Looks like he's diabetic. And his triglyceride HDL ratio, again, another one of these lipid ratios, is 8, with a goal being less than 2. So we're going to ask the question, where the heck is the triglyceride coming from? And what do we do about it? Case number 3, follow-up pre-diabetes visit. Patient's actually doing better. When we look at the A1Cs, 5.8, 5.4, 5.9, and 5.6. So the question to initially ask, if the pre-diabetes is better at 5.6, why are his triglycerides so high? Look at the total cholesterol, 245, the triglycerides, 252. The non-HDL cholesterol is 207. And what does non-HDL cholesterol really mean? Do you use that a lot in practice? What does it mean? And why is the HDL so low? Because we've seen this a couple of patients here. And look at the LDL-C. That's 157. Is that too high? What does that mean? And then we notice over here we've got a fasting insulin level here at 45 and a fasting glucose here at 112. And we use those two numbers to calculate this HOMA-IR score of 12.6, normal being less than 2. And we have to ask ourselves, what is a HOMA score? And is that a useful test? And what's the C-peptide represent? And what's the significance here? What does the patient's metabolic status really mean? And the last case is that of Tim Russert. Tim Russert had a sudden, unexpected MI, June 13th, 2008. He was the host of NBC's Meet the Press. Now, many of us remember him on Meet the Press. Now, some in this generation never saw that show. But he was a very prominent fellow. He died of a heart attack at age 58, and believe it or not, at the time before his death, he had an LDL-C from his most recent physical exam, and his LDL-C was less than 70. What happened to him? Here's a study of 136,000 patients who were admitted to hospital with coronary artery disease, and they had admission LDL-C. About half the patients, the LDL-C was less than 100, and the other half was over 100. And almost about 20% of the patients had an LDL-C of less than 70. And that's where Tim Russert was, right there. And so it goes to show you that LDL-C, the ability for LDL-C to predict the presence or absence of coronary artery disease is pretty limited when you start looking at it. And again, there have been no randomized control trials that link LDL-C with coronary artery disease. There have been observational studies, but no randomized control trials. Back to our original patient. In retrospect, case number 1. LDL-C was not a factor in predicting this heart attack. This fella on 3/23/2020 had a STEMI, an ST elevation MI, due to the total occlusion of the distal LAD. And for 7 years before his heart attack, his LDL-C was perfectly controlled. Here's a study of LDL-C, and it's a study of over 3,000 patients tracked over 8 years. And they compared LDL less than 130 to LDL greater than 130, and they compared that, the endpoint of the study being coronary artery disease, and they compared that to the ratios of total cholesterol over HDL cholesterol. And they looked at the hazard ratios. And again, a hazard ratio of greater than 2 is acknowledged to being significant cause. Okay, so it is acknowledged to be significant, and it implies a high risk of heart disease here in this study, the way this study was set up. So the bottom line from this study was that we had hazard ratios of significance with people total cholesterol over HDL over 5, in people with LDL cholesterol less than 130, and we had significant hazard ratios of total over HDL cholesterol over 5, greater than 5, with LDLs greater than 130. So really, we had just the same hazard ratio with low LDL cholesterol as high LDL cholesterol. The ability to really predict was the ratio of total cholesterol to HDL. So in other words, total to HDL ratio predicts the risk much stronger than whether or not the LDL-C was low or high. So what's the traditional advice that we have been giving our patients? Let's start here. Let's continue here, huh? Okay, so again, we've got these macronutrients. We've got carbohydrates, proteins, and fats. And the fats are sort of been divided. You've got the saturated fat, the monounsaturated, the polyunsaturated, and the trans fat. Now, the trans fat have been the ones recently marked as dangerous to our health, and they've taken these out. But you know, they originally came out, I believe it was in the 80s or the 90s. They were supposed to be, you know, super duper and helping us and making life so much better, because the villain here was always the saturated fat. And again, that was based on no randomized controlled trials. It was based on just observation. And it took a long time to rectify giving people trans fat, and we're finally got that taken care of, and we are sort of in still this stigma of saturated fat. Now, the difference between saturated fat, monounsaturated, and polyunsaturated, I kind of like the analogy of a string of Christmas ornament lights or a string of lights. If all of the light bulbs are in, that's saturated fat. So in other words, this is just a long string of fatty acids. And so if all of the bonds are there, the hydrogen-carbon bonds, if all these bonds are there, it is saturated. But if there is a bond available that is not there, it doesn't have a bond, it has a double bond, those are called monounsaturated fatty acid chains. Okay? And then if there are several bonds that are not, if they're open bonds, that's sort of like a string of Christmas lights with multiple lights missing. And those are like polyunsaturated fatty acid chains. So you can think of fatty acid chains as like a string of Christmas lights. Either they're saturated with all the Christmas lights in, monounsaturated missing one Christmas light, or polyunsaturated missing several Christmas lights. The thing about these polyunsaturated is because they're missing several Christmas lights, they're missing bonds, they are more unstable, and they can tend to get oxidized easier and form radicals. And believe it or not, the research is pointing that the more unhealthy fats are the polyunsaturated and maybe a little bit of the monounsaturateds, but the saturateds are very stable. And so, again, so much of the confusion in nutritional science has been confusing the polyunsaturated fat with the saturated fat, and vilifying saturated fat because when you eat it, the LDL-C goes up a little bit. But again, as we're going to look a little bit more, LDL-C doesn't really have anything to do with arterial plaque formation. So that's one of the controversies that we kind of traditionally see right now. The other one has to do with protein. And there's a lot of people who enjoy eating meat, and then there's a lot of people who say, for religious purposes, I don't want to eat meat, or from, I have strong beliefs, like I want to be a vegetarian, I want to be a vegan, and things like that. And so again, personally, as a person and as a physician, I don't have any problems with people having that. The only concern I have is some groups are now taking this into the political arena, and they are trying to, put governmental restrictions on eating protein. And I'm not quite comfortable with that. People have been eating protein from animal protein for as long as time has been around, and people have been doing fine. Again, this is another area of controversy right now in the nutritional world. But again, other research needs to be looked at in the elderly population, because geriatric sarcopenia, the elderly and the frail with low protein makeup of their bodies do much worse in terms of their health. And when we get these fragile elderly patients who appear either with low total body protein and muscular development and things like that, if they fall, break a hip, they're much more at risk for falls. But even if they're down for pneumonia for a few days, and then they get up, they get so weak, you have to almost teach them how to walk again. We have a lot of PTOT for these folks just because they can get cachectic or sarcopenic so fast. So protein is a really important macronutrient, just like we're going to make the point that fat is too. So we do have essential proteins. We do have essential fatty acids. But over here on the left, we've got carbohydrates. And it seems like with the controversy around protein sometimes, the controversy around the fats, the dietary recommendations have been really shifting over here to eating a lot of carbohydrate. Carbohydrates are sugars. And so the food industry is really loving this because so much food can be made from sugar or with sugar products, and it's very addicting. And you want to, I mean, this is where your synthetic food comes from. This is where your processed food comes from. The fat is taken out of the food, and we flavor it with all kinds of sugars. And so this is getting a lot of people into trouble, the overuse of carbohydrates. And we'll talk about this as we go on. The micronutrients, I just wanted to list. We've got minerals and vitamins, phytochemicals, antioxidants. I'm not going to really go into some of this in this talk, but I just wanted to acknowledge the micronutrients. We might point out the role vitamin D seems to be playing, especially in the arterial wall, when we start talking about the arterial wall glycocalyx, and as that pertains to small, dense LDL particles. So traditionally, doctors have sort of thought of the advice to patient as sort of a calories in, calories out kind of phenomenon here. Calories in being the proteins, fats, and carbohydrates, the macronutrients, and that supplies your calories. And then that's sort of what you bring into your body. And then what you do, your exercise, daily activities, and your metabolic rate sort of is how much and how fast you burn these calories. And if you take in more calories, you're going to gain weight. And if you burn more calories, you're going to lose weight. And that is, in general, the calories in, calories out theory. And one famous kind of a quote is, it takes, you got to burn about 3,500 calories to lose a pound of fat. So if you're about 3,500 calories and you have to burn 500 calories per day, in 7 days you'll lose a pound of fat. And so to lose 20 pounds of fat, you would multiply that by 20 and you're going to get 140 days. So traditionally, doctors have been telling patients, if you can burn 500 more calories a day than you consume, you're going to lose a pound a week. And after about almost 5 months, you should be able to metabolically lose 20 pounds. And that is based on the calories in, calories out theory advice. So then you have to sort of say, before we get into it, it's almost like a thermodynamic kind of posture. If you just dial down the calories and dial up the exercise over here, your body's going to, adjust and you'll lose weight, right? It's almost like your body is behaving according to the principles of physics here. But the reality is that it really doesn't work that well. Why? Well, just look around. There's an obesity epidemic. If it was just as easy as calories in, calories out, we wouldn't have an obesity epidemic, would we? And the research says that about 98% of people who lose weight on a diet will gain it back within 5 years. That's terrible. 98% of diets fail. About 90% of people who lose weight will gain back more weight than they originally lost. And only 5 or 10% of people will gain or maintain a weight loss that's greater than 10% of their initial weight. So 98% of these diets are really failures. That's just terrible. So what's the reality of the calories in, calories out theory? Are Twinkies really equal to, let's just use steak as an analogy? My apologies to the vegetarians out there, but let's just, to make the point, is a Twinkie equal to a steak? And the answer is no. Why? And that's where we're coming to. The fact that the body does not obey the principles of thermodynamics when it comes to weight. Why? Because the body obeys hormones. We have hormones, and our big hormonal reality is that insulin is a hormone that governs our weight loss or our weight gain. And it is this milieu of insulin and glucagon that control that reality. I've made this point multiple times with patients, but I just can't resist going over it one more time for you here right now. The physiology of carbohydrate impact on diabetes and obesity. Sugar, we all know sugar. It's a monosaccharide. And we relate to sugar. We know candy, ice cream, and chocolate and all that other stuff are sugars. And if we want to lose weight, we say, oh, I'm not going to eat as much sugar. But sometimes we don't think that when we put all these sugar molecules together, they form polysaccharides. Those are carbohydrates, otherwise called starches. And it's interesting that sometimes we don't relate to our carbohydrates like we do our sugars. Our carbohydrates, bread, rice, pasta, potatoes, they seem like healthier foods than eating a bunch of ice cream or candy bars or Twinkies. Flour or wheat, grits, oatmeal, things like that we eat for breakfast, we take for granted, but those things are carbohydrates too. And when you break them down, they all go back to sugar. Regardless of whether you're eating these complex starches or simple sugars, insulin is going to get triggered regardless. It is the quality of the calorie, not the amount. The amount does play a role, but it is the quality of the calorie. So sugar triggers insulin. Insulin is secreted from the pancreas and it helps metabolize the sugar. Insulin has to do a really important job. Sugar, you can't have more than a teaspoon of sugar in your bloodstream. Insulin is there to regulate sugar metabolism. And what happens is over the years, when you have greater and greater amounts for longer and longer periods of time, your body is exposed to sugar. Your body has to make more and more insulin to handle the same amount of sugar. And over time, your body gets resistant to the insulin because your body has to make so much. And then you get this insulin resistance beginning to set up, and your body's got to even make more insulin to handle the same amount of sugar coming in. And pretty soon, that normal blood sugar, there's a little bit of sugar left over. Now that normal blood sugar is that leftover sugar puts the patient in the pre-diabetic range or even the diabetic range. And after a while, Uncle Joe he goes from normal to pre-diabetes, now he's diabetic. At the same time, the insulin levels are so high, the insulin has another effect on fat tissue. It inhibits the body's ability to metabolize fat. And it actually stimulates the body's ability to make fat. It stimulates de novo lipogenesis. insulin is a fat growth hormone. If you want to make somebody fat, give them insulin. If you want to get fatter and fatter, make your insulin levels higher and higher. Okay? So, we see an obesity epidemic as well as a diabetes epidemic. Why? What is driving it? Insulin. Insulin is driving it. Insulin is a fat-producing hormone. So I put a few little handy-dandy ratios up here for you to keep in your hip pocket. About 25% of the U.S. population is diabetes type 2, and about another 25% of the population is pre-diabetes, and then about another 20% or so are these pre-diabetes. In other words, the person has a normal blood sugar but is insulin resistant and doesn't know it. They're destined to be diabetic and they don't even know it. And the doctor doesn't even know it too, because to the doctor, blood sugar is normal. And the doctor may not be paying attention to the insulin level. And that's why that HOMA score comes into play, or getting a C-peptide comes into play, that fasting insulin level. Because what we've got here is metabolic insulin resistance syndrome, otherwise called metabolic syndrome, or diabetes type 2. So the point I wanted to make from this slide is that diabetes type 2 is really a metabolic syndrome based on insulin, hyperinsulinemia. And far too frequently, I think as physicians, we zone in on the glucose and we are ignoring what's going on with the insulin resistance. And if we can address insulin resistance sooner, we can potentially reverse this progression from pre-diabetes to pre-diabetes to diabetes. We can reverse this progression of obesity and help people start losing weight. Again, sugar is really making us fat. Not eating fat. So again, physiologically, people are getting fat because they're eating sugar, not because they're eating high amounts of saturated fat. This is from Virta Health. I really like this little slide because it's so simple. Another way of thinking about insulin resistance. It all starts with eating a bunch of sugar. More sugar than you need over many, many years. It causes insulin to be produced, and over time you have to release more and more insulin, and over time that more and more insulin makes the body more resistant or less sensitive to the insulin, and because of that you have to have even more insulin the next time you eat the sugar, and then you release even more insulin, and you have this cycle of insulin resistance. Insulin resistance is a reaction that the body has to respond to. This is a body's response to the conditions that we're giving it. It's not like the body's at fault. The body is responding to what it's having to deal with. Here's another one. This was from Jason Fung's book. I believe it's from the book called The Diabetes Code. I really like this book. It's a good book if you wanted to read it. This is sort of an analogy. It's sort of a way of thinking what insulin resistance is. This lady here is trying to sit on a suitcase and pack her suitcase. The suitcase are like the cells of the body. The woman is sort of like insulin, and the clothes are sort of like sugar. And insulin resistance is when the cells just cannot accept any more insulin. The body gets insulin resistant. And more clothes come in, and you've got to put more and more clothes on your suitcase, and you're sitting on it. You're trying to pack as much as many clothes into this suitcase as you possibly can, just like the body is trying to pack as much sugar, as much free glucose, free energy into the cellular tissue as possible. So the body, the only response is to make more and more and more insulin to achieve this, and the body also gets fatter and fatter and fatter. Here's another one from Jason's book. I really like this too. This is from a picture, I believe it's from Japan, and they have these subway cars, and when the subway car stops, people get on here, and the people are sort of like blood glucose, and the subway car is sort of like the tissues, the cells. And they have these porters here. Just before these doors close, they help push the people into the subway cars a little bit more. Okay, so they push so that they can get a maximum amount of people in the subway cars before the subway cars get ready to take off again. And this is like what insulin's trying to do, is trying to get as much sugar into the cells as possible to keep the excess glucose out of the bloodstream. We are trying to regulate blood sugar. Now remember, I said you can't have more than a teaspoon of glucose in your bloodstream at any one point in time. That's what insulin is trying to do, is trying to keep the blood sugar low. Because when you have a lot of glucose hanging around, then you start getting tissue damage, and the body is set up for more oxidation. And the body gets oxidized also from these high insulin levels too. So both of these things are not good if these levels are too high. So it's another way to think about insulin resistance. Again, what drives serum glucose? Well, it's carbohydrate. Carbohydrate is sugar. Serum glucose is affected by carbs. Does sugar go up when you eat protein? Not a lot. Not as much as carbs do. Carbs just shoots it right up. So from a diabetic standpoint, eating protein is much more favorable than eating carb. And saturated fat, it doesn't cause your blood sugar to go up at all. Now we've been talking about the physiology of carbohydrate. Let's talk about some physiology a little bit of fat. Because carbohydrate is a form of energy and fat is a form of energy too. So let's think about this for just a minute. So fat comes in here into our body. We eat it, dietary fat, and it gets broken down to triglycerides, cholesterol, and the fat comes in as fatty acids. The cholesterol is picked up also, and it forms chylomicrons. And these chylomicrons go to the liver. And the liver takes these chylomicron remnants and uses the HMG CoA enzyme system to synthesize cholesterol. That's one of the places that we get cholesterol. So we get cholesterol from our diet, but the liver makes cholesterol. So a couple of different thoughts about cholesterol. Now, the cholesterol then gets packaged over in the ApoB system. ApoB is apolipoprotein B. These are like ferry boats that are kind of like shuttle boats to take supplies around the body. So these chylomicron remnants are here, and we have triglycerides being made also in the liver. Now, we have to think about where that comes from. And so I'm taking a pause, and it's not really written out on this slide for a second, but let me tell you another little story, because when we talked about glucose and insulin, insulin is shoving extra sugar into all the tissues of the body, and another tissue that it is shoving glucose into is the liver. Now, when glucose gets shuttled into the liver, that glucose gets stored, it gets converted into glycogen. So we have glycogen synthesis that is occurring in the liver. Okay? Now, if for some reason, like during the night or you're skipping a meal and your glucose levels drop, that glycogen can get converted back to glucose. And so glycogenolysis occurs and we have glucose again. And so this will be a really good storage area for the extra sugar. But it is a storage, and again, the liver also converts extra free fatty acids and extra proteins also to glucose through another biochemical pathway called gluconeogenesis. Okay, so the liver is all about energy. You don't think of it as an energy organ, but it is. It stores sugar in the form of glycogen, and it converts other nutrients, fatty acids, and proteins back over to glucose. Okay, now at some point, and remember we said insulin is just cramming glucose into the tissue. So when it's cramming glucose into the liver will get to a point where it says, I can't take any more glucose. It maxes out. And at that point, the liver begins packaging and converting glucose into triglyceride. This is a big deal. It is a big deal. So now we have hepatic triglyceride formation. And the hepatic triglyceride formation is being driven by the insulin, hyperinsulinemia, insulin resistance of the body. It is driving more and more sugar to be brought into the liver. And when the liver can't handle any more sugar, it starts converting that sugar. It can't convert it to any more glycogen. Now it starts converting it over to triglyceride. Now, at that point, that triglyceride's got to go somewhere. It can't stay in the liver. So it gets packaged. It gets packaged in the ferry boat here. The VLDL, which is carried around by the lipoprotein B. And so we have this VLDL, like the big ship that gets released out to sea in the open sea. And now the VLDL is carrying triglyceride, which is the energy, as well as the cholesterol that came in either from the diet or that was made by the liver. Now, we're going to make the point that cholesterol is utilized all over the body in a minute. But we are going to make the point that the VLDL system is carrying triglyceride as an energy source, kind of an exclusive energy source here. And as VLDL gives off free fatty acids as energy, it gets a little smaller into intermediate density lipoprotein. As that gives off a little bit more free fatty acid, it gets a little smaller to LDL. This is your LDL-C that we are measuring when we do our lipid analysis. Okay? So LDL-C then gives off fatty acids also once it gets down to the actual fat tissues. And if the body is able to utilize that for energy, lipoprotein lipase will cleave off the triglycerides into free fatty acids, and those free fatty acids, if the hormonal conditions are favorable, in other words, if insulin is lower, then those free fatty acids will be converted into keto acids and they'll have an energy supply. If insulin levels are super duper high, these free fatty acids are going to be incorporated into more and more fat. more and more fat tissue. So we are taking our glucose energy, converting it to fat, sending it out to the tissues, and we're either going to be making fat or burning the fat. Now, fat, the triglycerides that are left over are going to be conserved. The HDL system is going to clean up the leftovers, and it is going to carry those back to conserve this energy back to the liver. And that's through the ApoA system, apolipoprotein A system. And it will also bring back any cholesterol excess from the cells as well. Now, the extra cholesterol is brought back to the liver, and that excess cholesterol is made into bile and excreted from the body if there's extra cholesterol. The triglycerides can be repackaged back into VLDL again and recycled. So the liver has an interest to keep that extra triglyceride in circulation for energy to the body, or incorporate it into fat, or let it be burned by the body. So, again, we are packaging triglyceride along with cholesterol, and cholesterol is kind of like a passenger. And this system, whether or not we burn the free fatty acid or make fat, depends on the insulin-glucagon ratio. Depends on the insulin levels like we were talking about before, because insulin is a hormone, and high insulin levels will stimulate fatty acid synthesis. And saying that another way, hyperinsulinemia stimulates de novo lipogenesis. Let's talk about this one more way. It is in an energy-heavy system. If we've got a lot of sugar now in the liver, we are going to be making a lot of VLDL. And then you're going to have remnants of that. And as this gets metabolized, and as free fatty acid keeps being distributed, you are going to eventually have more and more LDL particles, and they get smaller and smaller, and the greater numbers will result in a large number of small LDL cholesterol particles that are small and dense. Those are called small, dense LDLs. So they are there because of the high energy in the system, and that has been driven by hyperinsulinemia. And that results in these small LDL particles. And the small LDL particles, because they're smaller and there's so many of them, they have a greater oxidation risk. And so these small LDLs can be oxidized and cause trouble. And then the HDL, on the other hand, because there's so many more small dense, greater and greater amounts of HDL get used up. So they're consumed because of the fact that they have to clean up the remnants of the small LDL cholesterol. So this is sort of a concept about lipoproteins and triglyceride as an energy system. And we need to think about this as it impacts the body metabolically, because it is a response to energy. So the lipoproteins transport triglycerides as energy, and look at all the different ones that we've been talking about. We've got chylomicron remnants, so we really don't measure that much when we do lipid testing. VLDLs, now VLDLs are generally reported out as non-HDL. This is the non-HDL cholesterol. But if we've got high VLDLs, that'll drive this number up. We're not like specifically measuring it in the lipid analysis. But if VLDLs are going up, if we're producing a lot of these, it's sort of almost like the bilirubin with the indirect and direct. The indirect is sort of a calculated number. Well, this is sort of an inferred number of increasing amounts of VLDL. Intermediate dense lipoproteins are sort of like as we give more and more fatty acids away, that turns into more and more LDL cholesterol. But again, the size of this has to do with giving off of the triglycerides. Now, one we haven't talked about is the LP little a. And this is often called the little rascal. Now, again, it's not reported out in the lipid profiles, but LP little a has been associated with early heart attacks in younger people, like in their 30s and 40s, people having early heart attacks. And if there's a family history of early MI, you might want to check for LP little a. And that's a significant cardiac risk factor, is atherogenic. So when we look at this, again, all of these, the non-HDL-C, are all transported by this apolipoprotein B system, and the HDL cholesterol, which is the sort of the conservation lipoprotein, is being transported by the ApoA system. Okay, so the lipoproteins are transporting triglycerides as energy, and we distinguish that as they're also transporting cholesterol as a passenger, but cholesterol is there not to supply energy. Cholesterol is necessary for the synthesis and repair for the 40 trillion cells that you've got in your body. You've got to have cholesterol. Every cell in your body is made of cholesterol. The cell walls are cholesterol. And the hormones in your body are made of cholesterol, from estrogen to testosterone to, aldosterone to, adrenaline. All of these hormones and endocrine functions are dependent on cholesterol. And when you look at your brain is 60% of your brain is made of cholesterol. And so one of the things that we've got to be aware of is in our elderly patients who are taking these statins, we have to be aware that the statins are inhibiting the production of cholesterol, and cholesterol is really needed by our bodies. And when we continue to vilify LDL-C and we put elderly patients on statins, we are not only reducing LDL-C that the body needs, we're reducing LDL-C that the brain needs. And many of these patients will have mild cognitive impairment, which is a side effect of statins. And there's a high correlation between dementia and statin use. So we've got to be aware of that. And also you have to remember that when you inhibit cholesterol formation, you are inhibiting HDL formation as well. So HDL, one of the protective effects of HDL is inhibited as well. So any oxidized small dense LDL that is out there has less of a chance on getting back to the liver. So again, cholesterol is really not an energy source, it's just a passenger. So in summary, we've got these energy batteries that our body uses. And the liver has this glycogen battery. The liver can hold about 2,000 calories of glucose. It's stored as glycogen. And it's best not to overfill the liver with glycogen. We want this to sort of be a give and take. It's mainly for short-term energy. Like when you miss a meal, the glycogen will break back down to glucose, and that'll shoot some glucose out for you to keep your serum glucose in a good range. However, the liver can be thought of as sort of a battery converter too, because it converts glucose to fat. it converts glucose to triglycerides and packages them in VLDLs, and these VLDLs go out into the body and give off triglycerides, and they shrink down and become LDL-C. And so this is sort of this overflow. This is like a fail-safe overflow safeguard, I would say. When you get insulin resistance and you get so much glucose storage in the liver can't handle anymore. Now the liver performs this metabolic miracle that converts glucose to fat. And the third area of the body that is sort of like a storage battery is the actual fat tissue itself, the body, the visceral fat. It's a final storage depot. This is the final area where the triglycerides get deposited in the fat stores, in the visceral fat stores. And this will either be a source of energy or it'll be a source of fat. Now, that fat, if the patient is hyperinsulinemic, that fat is going to get made there and is going to get stored. But if they can reverse that process, if they can lower their carbohydrate intake and lower their serum insulin, their glucagon will take over and allow that fat to start being metabolized under the lipoprotein lipase system. So again, this visceral obesity is sort of like this final storage of energy. The glucose that came in that was overfilling the liver gets converted to triglyceride, and the lipoproteins take it around the body, and the intestinal viscera are very, very hormonally sensitive to insulin. And so these excess carbs finally get stored as fat. And so when the liver can't take any more, then we just start making fat in the belly. So the fat in the belly really is where we're putting all our extra sugar. The fat in the belly is where we're putting all our extra energy. And it's regulated by insulin. And, a lot of people even measure the waist to hip circumference. Waist to hip circumference. If the waist is greater than the hip, you think of insulin resistance. But this visceral obesity is implying insulin resistance. It's been said all those who cannot make enough insulin become diabetic. If you can't make enough insulin due to extreme insulin resistance, you'll end up being diabetic. Why? Well, that means your blood sugar goes up and you get fatter and fatter. So again, the visceral fat is central obesity. This fat is not dietary fat. This has nothing to do with the fat that you eat in your diet. This fat comes from triglyceride production produced in the liver, and it is due to hyperinsulinemia, due to excess dietary sugar from carbohydrates. So high insulin is going to inhibit lipolysis or weight loss. High insulin means you're going to go to the gym 5 days a week, you're going to work out 5 days a week, and you're not going to be able to lose a pound. That's because you have hyperinsulinemia. And the high insulin is stimulating de novo lipogenesis. In other words, it is stimulating your body's fat production. So visceral fat comes from eating too much sugar, not eating too much fat. And our fat-free foods are spiked really, really high in carbohydrate. We're going to see that as we proceed. And this is a busy slide. I just wanted to show you that there's a lot of biochemistry here. But again, the root cause here is hyperinsulinemia and insulin resistance that leads to the hepatic conversion, the liver conversion of glucose into triglyceride. And that starts this process of what we call fatty liver. And if it continues, this fatty liver leads to steatohepatitis, It can actually cause inflammation now in the liver, and then eventually fibrosis or even cirrhosis. So the liver does pay a price for this biochemistry, but again, non-alcoholic fatty liver disease, the trouble is sugar, the exposure to sugar causing hyperinsulinemia. So we're going to stop here, and the next time we get together, we're going to look at metabolic syndrome. So thank you, and we'll see you next time.